Welcome to IM Updates. This is Yen. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from July the 3rd to July the 10th. Here's the overview. On July the 3rd, the Advanced Prostate Cancer Consensus Conference published Diagnosis and Staging of Patients with Prostate Cancer report. This was the first APCCC focused exclusively on diagnostic aspects of prostate cancer. Consensus was reached on only 19% of questions, 17 out of 88, highlighting substantial controversy and evidence gaps. On how to diagnose prostate cancer, strong consensus of 90% against routine blood or urine biomarker testing in men with PSA 3 to 10 nanogram per milliliter, and normal digital rectal examination. 93% recommend PSA-based screening for BRCA2 carriers starting at age 40. 79% recommend PSA-based screening for patients with family history starting at age 45. About how to stage prostate cancer, consensus of 79% recommend digital rectal examination when exploring treatment options if no prostate MRI performed. Strong consensus of 90% recommends PSMA PET-CT for staging clinically high-risk localized or locally advanced prostate cancer. Consensus of 85% do not consider whole-body MRI as valid alternative to PSMA PET-CT for high-risk staging. For biochemical recurrence scenario, strong consensus of 96% in that absence of distant lesions on PSMA PET increases likelihood that local salvage benefits patient. Consensus of 81% recommend PSMA PET-CT before treatment of BCR regardless of previous treatment, PSA level, or kinetics. For metastatic disease, consensus of 77% recommend PSMA PET-CT for patients with grade group of 4 or higher and suspect pelvic or abdominal nodal disease on CT with normal bone scan. Consensus of 80% supports no additional routine imaging if PSMA PET shows bone metastasis with sclerotic CT correlates. On June the 9th, the European Society for Blood and Marrow Transplantation published recommendations on cellular therapy in mantle cell lymphoma. Key recommendations include: first, risk categorization of MCL. High risk includes TP53 mutation or deletion, P55 expression over 50%, Ki67 over 30%, high MPC, blastoid or pleomorphic variant, progression of disease within 24 months from start of first-line therapy, minimal residual disease, persistence post-auto HCT. Low risk is indolent MCL, which is non-nodal or asymptomatic nodal with low Ki67, and standard risk is all others not falling into high or low risk categories. Second, CAR T-cell therapy is mainly indicated for second-line progressed on Bruton's tyrosine kinase inhibitor or BTK inhibitor and CAR T naive. No strict upper age limit, eligibility based on performance status, comorbidity, and age collectively. Riluzole and liso-cel are EMA approved after more than 2 lines including BTK inhibitor. Liso-cel has less neurotoxicity while riluzole has shorter turnaround time. Third, autotransplantation is indicated as first-line therapy for high-risk patients except TP53 mutations or standard risk without BTK inhibitor. No strict age cutoff, but benefit questionable over 65 years. Beam is standard conditioning, TBI or Buci are alternatives. Rituximab maintenance for 3 years is recommended post first-line auto HCT. Fourth, allo HCT can be considered for patients progressed on BTK inhibitor first line or no CR on second line BTK inhibitor and no CAR-T access or after CAR-T failure. Reduced intensity conditioning is preferred. allo-HCT can overcome high-risk features, but disease status at transplant matters. CAR-T should be preferred over allo-HCT in BTK inhibitor refractory patients. Move on to FDA news. On July the 7th, the FDA has approved Rituxan to reduce proteinuria in adults with primary immunoglobulin A nephropathy at risk for disease progression. The primary efficacy endpoint assessed the change from baseline in proteinuria after 9 months of treatment in the first 203 patients who had the opportunity to reach the month 9 visit. At 9 months, patients in the Rituxan group had an average 46% reduction in proteinuria as compared to proteinuria in the placebo group. Rituxan suppresses the immune system and may increase the risk of infections. On July 9, 2026, the FDA approved saxiflisahasana for subcutaneous injection for multiple myeloma indications. The specific indications approved for saxiflisahasana are in combination with pomalidomide and dexamethasone for the treatment of adult patients with multiple myeloma who have received at least one prior line of therapy, including lenalidomide and a proteasome inhibitor, or in combination with carfilzomib and dexamethasone for the treatment of adult patients with relapsed or refractory multiple myeloma who have received 1 to 3 prior lines of therapy, and in combination with bortezomib, lenalidomide, and dexamethasone for the treatment of adult patients with newly diagnosed multiple myeloma who are not eligible for an autologous stem cell transplant. Efficacy of saxiflisahasana administered subcutaneously in combination with pomalidomide and dexamethasone was evaluated in Iagaru trial. Overall response rate was 71.1% in the subcutaneous arm and 70.5% in the intravenous arm. Efficacy of saxiflisahasana administered subcutaneously in combination with carfilzomib and dexamethasone was evaluated in Iagaru trial in 74 patients in a phase 2 clinical study in patients with relapsed and/or refractory multiple myeloma. The efficacy outcome measure, ORR by IRC, was 79.7%. Efficacy of saxiflisahasana administered subcutaneously in combination with bortezomib, lenalidomide, and dexamethasone was evaluated in 74 patients in Iagaru trial, a single-arm investigator-sponsored phase 2 clinical study in patients with newly diagnosed multiple myeloma who are not eligible for stem cell transplantation. The efficacy outcome measure ORR was 97.3%. The prescribing information includes warnings and precautions for hypersensitivity and other administration reaction, neutropenia, infections, secondary primary malignancies, laboratory test interference, and embryo-fetal toxicity. On July 10, 2026, the FDA approved Keytruda or Keytruda QLEX, each in combination with Padcev, as neoadjuvant treatment, followed by adjuvant treatment after cystectomy, for adults with muscle-invasive bladder cancer. This extends the prior approval for the regimen in this setting from patients who are cisplatin ineligible to all patients with muscle-invasive bladder cancer who are candidates for cystectomy. The major efficacy outcome measure was event-free survival assessed by blinded independent central review. Overall survival was an additional efficacy outcome. The trial demonstrated statistically significant improvements in event-free survival and overall survival in patients treated with perioperative pembrolizumab and Padcev, compared with neoadjuvant gemcitabine and cisplatin. Median event-free survival was not reached in the pembrolizumab with Padcev arm and was 48.5 months in the gemcitabine and cisplatin arm. Hazard ratio is 0.53. Median overall survival was not reached in either arm. The overall safety profile of pembrolizumab with Padcev in Keynote B15-EV304 was similar to that observed in prior trials of this combination in urothelial cancer. The prescribing information for pembrolizumab includes warnings and precautions for immune-mediated adverse reactions, infusion-related reactions, complications of allogenic hematopoietic stem cell transplantation, and embryo fetal toxicity. The prescribing information for Padcev includes warnings and precautions for skin reactions, hyperglycemia, pneumonitis or interstitial lung disease, peripheral neuropathy, ocular disorders, infusion site extravasation, and embryo fetal toxicity. That's all for today's episode. Thanks for watching. See you next week.